Hello everybody and welcome to this Kidney Cancer Support Network Click and Chat special. Today I'm delighted to be joined by Steve Leung, who is a consultant from the Western Hospital in Edinburgh. That's my brief introduction to Steve, so I'll let Steve explain in detail who he is, what he's done and what he does before we go into some questions.
That's great. Thanks for the introduction, Steve. Yeah, my name's Steve Leung and I'm a kidney cancer surgeon in Edinburgh in Scotland. I work in the Western General Hospital, and our kidney cancer service supports 3 other health boards as well. And so we're a busy tertiary referral centre for kidney cancer.
Very good, and we're delighted that you've done a bit of work with us, Steve, and vice versa. We do a little bit for you, I know, and it's great to have you on board and be prepared to do such a thing that can only benefit the members of the support group, and we really do appreciate your time.
Yeah, thanks for the opportunity, Steve.
Great. Okay, so if we fire into some questions, we put some questions out to the group members, and we selected a few, and it means by no means the ones we didn't select means that we don't value the questions. We are going to split this into 2 interviews to keep it nice and simple for people and not to go on to too broad a subject all at once. So if we start with one that we get asked a lot on the forums, really, and there's one that I wondered on my diagnosis. So what is the difference between the types of surgery that people are offered on a nephrectomy? Because we know there's open or keyhole, there's laparoscopic radical, there's many. If I try and list them all, obviously you'll tell me there's more. So, and basically, what makes you decide what patient gets what?
Yeah, and you know, there's lots of names and labels put to different types of procedures, but you can group them into really 2 big groups. And the first group is open surgery. And that kind of says what it says in the tin, which is the way to conduct the surgery is through an incision in the abdomen. And so the open surgery can be used for radical nephrectomy or total removal of the kidney, or even partial nephrectomy. And so that's open surgery. And when you come to what most people call keyhole surgery, or minimally invasive surgery, the beginnings of that were really what we call laparoscopic surgery, and that's a technique by which you inflate the abdomen with gas, usually carbon dioxide. So that inflates the abdomen, gives you room to then put your laparoscopic instruments in. So laparoscopic, keyhole, small cuts in the body, and that allows the surgeon to use these instruments to then do kidney surgery. And then from laparoscopic surgery, we move on to robotic surgery. So you might hear of it being called, robotic assisted surgery. And so the surgeon's still involved, but instead of him being connected to those laparoscopic instruments, he's actually then using a robotic platform, a robotic system, the Da Vinci robot, to then maneuver these small instruments in the body to then conduct surgery. But also within robotic surgery, you've actually got somebody at the bedside who's doing the traditional laparoscopic element of it, which is, they've either got instruments to help the surgeon use the robot to do the surgery. So 2 main classifications: open surgery, and then, minimally invasive surgery, which then, covers laparoscopic and then robotic surgery, if that department happens to have a robot. And then within the minimally invasive surgeries, you've then got variations of the theme. Some people have looked at doing keyhole surgery through just 1 wound, so kind of single site surgery. And again, that applies for robotic surgery. And then, some people use what we call hand-assisted, laparoscopic procedures. So, somebody pops their hand in to help remove the kidney. So there's variations of the theme, but those are the 2 main groups.
It's fantastic information and a real insight into the two different types. I mean, what I'd be interested there is how do you decide then who gets what and why?
Yeah, and I think this is a very interesting question. In the past, it used to be very simple. You know, it's kidney cancer used to be very just a surgical procedure, a surgical disease, and most of the time it was taken out by open surgery. But as technology moved on, then you've got um, conditions or diseases that used to be treated by open surgery, but now being able to be done by keyhole surgery. So the main things that a surgeon needs to consider when a patient comes to them with a kidney tumor or kidney cancer is the patient factors. So what what aspects of the patient are important to working out what the best treatment is. Then it's also the tumor factors as well. So very important to know, you know, information about the tumor, such as the size and location. And then finally into the mix, it's about the surgeon's experience. You know, what experience do they have with dealing with this particular type of tumor, and also what facilities do they have? Do they have access to a robot, or is it just keyhole surgery, um, or do they just do open surgery? So those are all the kind of considerations to take into account when working out what the kind of best approach is for a patient.
So if a patient was told they were going to have, for example, from what you've just said, an open nephrectomy, um, would you say that the patient should always go with that option, or would you advise sometimes maybe look for a second opinion to see if a less invasive treatment was available at another hospital?
I think this is the thing that you would want to get a feel from the consultation, and um, it is to try and get a feel for when your surgeon tells you what you need. So, for example, you've got maybe a 10 centimeter kidney tumor, so a reasonably large kidney tumor, and the surgeon says, well, definitely an open nephrectomy. Now, I think, you know, having just mentioned those kind of things that a surgeon should take into account, it's really for the patient to get a feel for whether the surgeon has perhaps considered all these things. And certainly when I talk to a patient, there are options on the table. And for me, with a 10 centimeter tumor, I would say, look, I have done quite a number of these tumors, and really talk to the patient about um, you know, how I've dealt with these tumors before. And I would offer the patient, keyhole surgery, but again, with the kind of proviso that, if it's difficult or challenging, then we may move to an open operation rather than continue with keyhole surgery. But yes, I think these are some of the questions that the patient should ask is, you know, how many have you done? Do others consider keyhole surgery in this situation? And I think you know for treating, say, small renal tumors, small kidney tumors, um, it is the decision between the surgeon and the patient after they've discussed various aspects of the disease. Where the tumor is, again, is very important, because the tumor can be, for small kidney tumors, be really accessible on the outside of the kidney. So it's what we call a kind of a simple location. There's various scores that surgeons can use to work out where a tumor is located and how complex it is. And then it's also, the patient factors. Do they have medical conditions that maybe threaten that other kidney? So it's to take all these aspects into account, what the patient feels is the best choice, and also surgeon experience. Do they have a robot to do partial nephrectomy, or is it just through open surgery? Or do they have experience doing laparoscopic surgery? and how successful that is. So these are all questions that patients should be armed with when they go and see their surgeon. And I think Kidney Cancer Support Network do have, information to help, prime patients for their kind of first consultation or even second consultations with the surgeons.
Yeah, that's great. I mean, obviously part of the work we're trying to do is to get into the hospitals at point of diagnosis, really, so people can get forearmed with them questions. Because I think what I took from what you said there is it really is important to go in with questions to your surgeon rather than just be told what is going to happen, and be part of that decision-making process.
Absolutely. And I think, in this current age, we want to be fostering sort of informed decision making and having a real partnership with, the caregivers, the surgeons, and the CNSs that are involved in a patient's care, and to really understand their disease and what the treatment options there are. And, for the patient to then be settled in that all their questions have been answered and that they've reached the right decision.
Fantastic. One of the things you slightly touched on, Steve, is one of the other questions we get asked a lot is what would make you decide to take a full kidney or a partial removal? Because we get a lot of concerns of, well, if they only take some of it, what gets left behind, or why are you taking a full kidney when there's only a tiny tumour? So it is a big question. It's a big concern for some people.
Correct. Yeah, and I think this is certainly an area of continued research and debate in the urological community. And maybe if we can go back to how partial nephrectomy came about. And partial nephrectomy really was done in the early days for what we call an absolute indication. In other words, if you only had one kidney left, and whether that was because of congenital reasons or it had been damaged because of infection or stone disease, if you only functionally had one kidney and you had a small tumor on that kidney, then you would do everything in your power to try and save the rest of that kidney. So that's a kind of absolute indication. And as experience has developed in doing partial nephrectomy, so moving from a kind of open operation to then surgeons being able to do it minimally invasively, first with keyhole surgery or laparoscopic surgery, then using the robot, then now the landscape has significantly changed. And now we're seeing that within a lot of the urology guidelines, the guidelines are advocating, if possible, nephron-sparing surgery or partial nephrectomy surgery for small renal masses, for tumours certainly less than 4 centimetres, but the indication keeps growing with surgeon experience. So there are more and more partial nephrectomy operations being done in the UK, and that's what the figures tell us. So going back to the original question, how do we work out as surgeons what the best the best choice for the patient is? And it's going back to those 3 factors that I was talking about. The patient factor, most importantly, what conditions do they have? So if perhaps they've got high blood pressure, diabetes, and and they've got other issues such as maybe stone disease or other factors that may harm that remaining normal kidney, then we've got to be careful about how we manage a tumor in that affected kidney. And then it's the tumor factors. So when we're talking about partial nephrectomies, we're talking about small kidney tumors on the whole. Where is that tumor? And is it in an easy location? Because what we know is that if the tumor is in a difficult location, then there are more risks to the operation, more adverse events to the operation. And also, there may be a higher chance that you may find it difficult to take the whole kidney out, the whole tumour out, without leaving any cells behind, something what we call positive surgical margins. And then finally, the other factor is the experience of the surgeon. You know, how experienced are they in doing partial nephrectomy? And, you know, if they're going to do partial nephrectomy for difficult located tumours, you know, what their experience is. And it's really having that, I suppose, detailed and nuanced discussion of all these factors to then come up with the right choice.
Fantastic information. It really does open your eyes to what the decision-making process is, rather than just being told this is what you're going to have and no real reason why.
Yeah.
So we know that people go in for the surgeries, they're obviously very nervous because it's major surgery, but it is becoming quite a routine surgery for most of you guys in your industry. I think the general rule is once you've had the surgery, you're looking at roughly around about a 6-week recovery. It tends to be the rough guidelines. But we do get found a lot of questions on post-operative recovery, general fitness, fatigue, back pain, etc., etc. So what would you say are the common side effects and why, really?
Yeah, I think it again boils down to what type of surgery you have. And for the maximally invasive surgery, the open surgery, for big kidney tumors, then again it's a detailed discussion with the patient, not just about the disease and the surgical procedure, but what the post-op expectations are. And so for the patients who have a big wound for removing a really big kidney cancer, or even for the patients who get an open partial nephrectomy for when you know, either the surgeon doesn't have robotic or laparoscopic you know, availability, then these are quite what we call morbid incisions. They cut a lot of muscles, they can cut nerves, and you can get things like weakness of the muscle. You can have long-term discomfort, especially some of the incisions that go into the rib, the kind of traditional loin incision. And that's how a lot of surgeons do open partial nephrectomies, is to go through the muscles in the ribs. And these are actually some of the most painful and uncomfortable incisions to recover from, but also have kind of long-term side effects, such as you know, having altered skin sensation because you cut some nerves, weakness of the wound as well, so hernia formation. And again, yes, you know, some people unfortunately do have some kind of long-term or chronic pain issues from some of the larger incisions. When we move on to minimally invasive surgery, then all these side effects are much less. But again, they also experience some particular side effects with minimally invasive surgery. A lot of them feel bloated because we've put a lot of gas in their abdomen. A lot of them have shoulder tip pain as well, and that's a very unusual side effect or you know, symptom and signs for patients to wake up to. So again, important in the kind of you know, counselling and discussion aspect is to make the patient aware what's coming ahead, so that they know they're prepared for that. I think a lot of people find that, you know, with that kind of associated bloatedness, a lot of the bowel function goes a bit awry. You know, they've starved for the operation, they eat a bit of hospital food, they're not feeling so well, they're on painkillers, and so going home, bowel function can take a little bit more time to recover, and so they can feel a bit bloated and uncomfortable. But for a lot of the minimally invasive surgeries, the wound is much smaller. Even the wound that the kidney is taken out of is much smaller. And so the main advice I have for a lot of the patients is, you know, to try and be a lot more mobile, move around. And again, that prevents any other of the kind of general side effects or complications from any major surgery, which are, you know, DVTs, clots in the legs, wound infection. So if you're getting out, up and about, That's very important. And fatigue is going to be an issue, especially for the patients who have major open surgery, but also, you know, having keyhole surgery. I do tell patients, even though when they look at their abdomen, there's only tiny scars there, it's still a major insult to the body. And so the body needs to recover from that, whether it's open or minimally invasive surgery.
Yeah, really informative. It is something we get asked a lot about, and it's good to know the reasons why. And I think, unfortunately, at times people tend to find when they have the consultation and are told what to expect after, recovery tends to mean to a lot of people when you're back to work.
Yeah, yeah.
And not the other bits that go along with it. And obviously then you're down to what job you do, how manual that is, and other life factors, I'm sure.
Yeah, and I think this is where having some of the literature that's available out there to then support patients in, you know, understanding not just their disease and what the treatment is, and focusing, say, on the operation, which again is very important, but also the kind of post-operative recovery, and you know, how they meet the challenges at home of what to expect when they've had surgery. So a lot of the units up and down the country have, you know, a cancer nurse specialist, and I think that support is very important to the patients to then not just talk about the disease and what was decided, but also what the kind of post-operative challenges will be.
Fantastic. Well, thanks very much for today, Steve. It's been really informative, and I know we're going to touch on a second part and look into metastatic and reasons why you may not do nephrectomy in part 2. But just again, from everybody at Kidney Cancer Support Network, thanks very much for your time.
Thank you for
And we look forward to part 2.
Great. Me too. Okay.